Good afternoon, everybody. We are here at the first Google Hangout of the Global Public Health MOOC. With us here today to help answer your questions on infectious diseases is Dr. Richard Cash, who is a visiting professor at the Public Health Foundation of India, advisor to our president, and also faculty at the Harvard School of Public Health. We will be starting in about a minute or so, so welcome. Okay, Dr. Cash, we can start whenever you're ready. Sure. Okay, so just to kick things off, we have a couple of questions that we've taken from the forum. The first one is why is the rate of, let me rephrase this, why are the incidence of infectious diseases so high in the developing world, and why interventions, say in terms of vaccines or vaccinations, for instance, why are they not so effective? And what do we do to address that?
Should I repeat the question?
No, you can go.
Okay. So the reasons that infectious diseases tend to have a higher incidence, greater prevalence in lower and sometimes middle income countries is because of a number of factors. Certainly one is the environment, that is the quality of water and sanitation. Of course, if the quality of water is not particularly good, or human waste and so on is not well taken care of, people have a greater chance of becoming infected with whatever pathogens are there. Other factors that may increase the incidence is crowding, and certainly in certain urban areas, the presence or prevalence of air pollution, which is quite bad in some cities such as Delhi, India, or Beijing, China. The nutritional status of children may, in fact, compromise them a bit. But much of what I've noted is this whole issue of water and sanitation and environmental issues. Now, the questioner also asked, or one of the questions asked, well, why isn't there an impact? The fact is that there's an enormous impact of vaccines on the incidence of a number of conditions, such as measles, pertussis or whooping cough, diphtheria, polio, tetanus. Polio has virtually disappeared from the world. There are a few cases in about 3 or 4 countries, but we don't see polio anymore. Smallpox was eradicated. Measles, the incidence of measles is way down. All of this has contributed significantly to the improvement of child and health in lower income countries. So in fact, our interventions have had an enormous impact. In addition to that, there are low-cost types of therapy, be it oral rehydration therapy for diarrhea, antibiotics for certain types of pneumonias, so that our impact on infectious diseases has been very significant.
There was also a question on how developed countries can support developing countries in addressing the issue of infectious diseases.
So the question is, how does the world as a totality respond to infectious diseases? And certainly there are a number of international and national efforts designed along this way. Gavi, which is the international program to provide low-cost vaccines, has been very active and successful in providing low-cost vaccines to low-income countries through a very effective mechanism. This has increased access so that in countries such as Bangladesh, which is quite poor, there is about 85% of children are covered with DPT, diphtheria, pertussis, tetanus, toxoid, and measles, and this has had a dramatic impact on their infant mortality, which is now in the 40s. So that's certainly one thing. The research and discovery of low-cost, effective drugs is another, and I should say research into other vaccines, such as rotavirus vaccine against diarrhea, such as pneumococcal vaccine against the common form of pneumonia. These are all activities which in the end will have a significant benefit to people in lower and middle income countries. There are also efforts to reduce the incidence of malaria and to provide a more effective treatment. All of these, however, any program that looks at treatment as the way of control is also vulnerable and limited because resistance can develop to some of these therapies. This is now happening with artemisinin and malaria, with certain antibiotics and so on. So far and away the best strategy is to try to prevent the disease from occurring at all. And that's where vaccines has such a powerful role.
Okay. Students, just a quick pointer to everybody. If you have a question that you would like to ask Dr. Cash, please use the Q&A section at the top right corner of your Hangout display. If you click on the grid, you can click on Q&A and then submit a question for us. In the meantime, there's also some questions on sanitation and what the impact of sanitation is on infectious diseases, and how addressing sanitation can deal with that problem.
The question is, what is the role of sanitation? Well, there are many roles that it has. One, by keeping feces, and when I say feces, I'm primarily referring to human feces, off of the ground, you can limit the spread of certain parasitic diseases, hookworm and so on, where the parasite resides in the stool. Also, through our fecal material, there are certain pathogens that cause diarrhea. By keeping those out of the water supply, such as putting fecal material in an area where it is unlikely to contaminate water, you will reduce these conditions, such as cholera. But sanitation is simply more than how we dispose of human fecal material. It also involves issues such as hand washing, particularly after we've used the toilet. It involves other contaminations that are not from humans, but rather the garbage and places. And the reason that this is important is it because where there is contamination of the environment, you're creating breeding sites for mosquitoes, for flies, and for other insects, which may, in fact, they themselves may spread disease. So by reducing the amount of human fecal contamination, by reducing the amount of garbage and other types of contamination, we both reduce the direct contact that we have with the pathogens that may exist there, but also reduce breeding sites for other, for insects and so on, which may in fact spread disease.
We have a question here from Manish.
The question from Manish is, one of the major issues is in the recognition of an epidemic. In Bangalore, in the last 2 years, we've had dengue and H1N1 cases. H1N1 is another type of influenza, reported in the media and private hospitals. But the government or the public sector failed to recognize that there is an epidemic. Well, I can't I can't comment directly on the response of the government of Bangalore to this, but a key element in the control of any infectious disease is in surveillance. What do I mean by surveillance? Surveillance is what we look for. We basically set up a system that tells us when there's an increase in a particular condition, or what the baseline is for that condition. So if we suddenly see an increase in respiratory diseases, we are suspicious. We say, well, maybe there is, maybe influenza is present in the environment. If we see an increase in other kinds, such as dengue, it also tells us that there is that we may be in the midst of an epidemic, particularly if the surveillance indicates that the incidence of these conditions are significantly above baseline. So one of the foundations of infectious disease control is setting up a good surveillance system, an early warning system, so to speak, a system that tells us, well, look out, something is coming, and so let's set up a way of identifying cases, treating cases, draining swamps, cleaning up the environment to either treat the people early in their illness when treatment is most effective, to actually prevent the spread of illness from person to person, or to clean up the breeding sites for mosquitoes, flies, and so on that may in fact spread illnesses such as dengue or chikungunya. Again, it is part of, in my view, the responsibility of all municipalities, all government, to make certain that they try to set up an effective surveillance system so that they can be there as an epidemic begins, rather than trying to react once it has gotten a full head of steam, which then becomes much, much more difficult to control.
Prakash, there's a question posted here and also on the forum. And both of these are related in that they ask whether, in light of, say, what's happened with the measles outbreak in the US, vaccination programs, should they be mandatory? And what role they play in public health?
This is a very difficult question, because the question is, should vaccines be mandatory? Many countries, in fact, make them mandatory in the sense that children can't go to school unless they're fully immunized. Now, parents may decide that they don't want to send their children to school because of that, because of religious or other beliefs. But if one is trying to reduce the overall incidence of a number of infectious diseases, you're trying to reach as high a coverage as possible, because those who are covered in some way provide a shield. We call it herd immunity, although it's not really herd immunity, it's more herd protection against those who are vulnerable, who are not immunized. And some children can't be immunized because they have immune deficiency disorders or other conditions that would mitigate against their being immunized. So the way that we protect those people particularly is by having very high rates of immunization. What happened in California was the rates dropped because certain parents decided that they didn't want to immunize their children. And of course, these children are the ones who then are the most vulnerable and are the ones who become sick. Can you force people to be immunized? Generally speaking, it's been done, but generally speaking, in this day and age, it becomes very difficult. And so the key is to find out, and most people, the vast majority of people, cooperate, are part of the system. But there are some who don't. And so I think that's the challenge of public health, is to convince these individuals that this is good not only for their own children, and it's after all the adults that are taking this decision, not the children, that it's good for their children, and that it will protect others in the community who cannot, because of their underlying illness, actually receive vaccines. What if people continue to refuse? As I say, different countries have taken different positions. Some have said you can't come to a school, public school, unless your child has been immunized. You cannot participate in certain events unless the child is immunized. Generally, these have been effective, but there are still people who will hold out and not do it, either because of a lack of information or what I would say was misinformation. For example, there was an article, turned out to be a bogus article, turned out to be actually the researchers were quite discredited, that linked MMR, measles, mumps, rubella vaccine, to the incidence of autism. Now, many studies followed this paper. None of them found this linkage, and it was found later on that the individual who in fact wrote this paper also had financial interests that would help him benefit if they moved away from MMR vaccine, or if people were sued because of the supposed autism. Now, this rumor has continued on way past the point of where it's been disproven. Some people still recall this paper and are fearful that this will trigger autism in their children. Again, there is no evidence for this. Now, if a parent refuses because of this, what do we do? Well, I suppose you could force the child, but that will ultimately backfire, and many others will not do it. You can try to provide evidence, and hopefully people will respond to the evidence that's there that says there is no linkage. And by the way, if you don't give your child these vaccines, they're going to become ill if they're exposed to them. And do you really want to put your child at that risk based on fallacious information? That's what you have to do. There are people who are increasingly studying why some people refuse, and sometimes it's on political grounds. That is, people see the state as imposing on their life, and so they're going to stop. They're not going to do it. Or on religious grounds. There are many reasons why people refuse. But I believe that the more you present evidence, the more you present a proof that this actually is beneficial, fewer and fewer people will, in fact, not have their child immunized. But it'll never be zero. And I think it's something that we have to live with.
We have another question here.
Sub-Saharan Africa is experiencing resistance to low-cost vector control measures for malaria, including pyrethroids. The cost of alternative measures, particularly carbamates, seems costly for most governments. How can we address this challenge? Well, where the cost of prevention exceeds the ability of a society to pay for it, going back to an earlier question, this is one role where the international community might step in and provide subsidized costs for slightly more expensive preventive measures. Where they haven't been able to do that, or have not done that, or there's been significant corruption that has prevented it from happening, then you are reduced to using maybe a lower cost but maybe less effective methods. We need to think of lots of different strategies. There is not just one. There are alternative strategies, some of which involve no medicines at all. simply the environmental approach to cleaning out swamps, cleaning out breeding sites, and so on. A strategy that was heavily followed and actually quite effective at an earlier time when the world actually came quite close to eliminating malaria from many, many countries.
We have a question from in the room here, which is on infectious disease and zoonosis more particularly. So the question is that how do we improve diagnostic capacity and general surveillance to improve the reporting on infectious diseases and zoonosis? And the second sort of tied-in question is, how do we bring together these various sectors, given that the origin of a lot of infectious diseases nowadays are through zoonotic routes?
Okay. So the question is, how do we respond in a better way to zoonoses? Now, most of the new and emerging diseases will in fact be zoonoses. That is, diseases that originate in animals, but then move into the human population and are spread, develop the ability to spread from person to person. So it starts out a flu that starts out in chickens, or originally they start out in ducks, and then the ducks give it to the chickens, and then chickens give it to us. And the key is, will we then give it to each other? Okay, because if it's just chickens giving it to us, we can stop monkeying around with chickens, whatever we do with chickens. But if it then develops, if the organism develops the ability to go from person to person, that's when we're in trouble. So one of the strategies that has been suggested and is being worked on is called One Health. And what is that? That's really the attempt to bring together those who study health in animals and those who study health in people, and get them to communicate better, so that when there is an outbreak of a particular illness in chickens or in hogs or in other animals, we find out earlier than we used to. We look at the mechanisms by which this takes place. There are a number of conditions, such as recently the Ebola outbreak, which is a zoonosis. Ebola, probably, though we haven't been able to prove it, but most likely the organism causing Ebola, the Ebola virus, probably resides in certain bats. Now, these bats themselves are not sick, but they can spread the illness to humans, not through biting, but through possibly defecation on food that we might eat, or having an animal causing illness in an animal through the same mechanism, and then we pick it up from an animal. For example, we may skin a monkey, a chimpanzee. This is called, in some parts of the world, bushmeat. And in so doing, we may cut ourselves, and then the blood from the animal gets in our blood, and we become ill. And then we go to some place where that illness becomes amplified, often in hospitals. That is, the person who has Ebola affects other people in the hospital, and then it spreads and spreads and so on. And that's exactly what happened in West Africa. So by trying to monitor illness in animals, we might be able to predict, or to, as we say, nip in the bud, those illnesses that might in fact get into the human population. That's not guaranteed. That's the hope. Now, one of the limiting factors, of course, is that we've got to be able to find the illness in animals, and that requires surveillance in animals, and particularly in wild animals. There isn't much funding for this sort of thing, and also to develop low-cost diagnostic measures that allowed us to make these diagnoses earlier and with far less expense and far easier than we've done in the past. The thinking being, if we can pick these things up early, if we can somehow prevent the spillover from animals to humans earlier on, then we might be able to sorry.
No, 1 second. Okay.
Let me continue with that thought, that if we can find out earlier, in both in domestic and in the wild animals, we can prevent the spillover and therefore anticipate the outbreak. As I say, this is far from guaranteed, but this is the hope behind this. Now, most influenza, as I noted, begins in wild ducks, and then ducks affect other animals such as pigs or chickens, and they then in turn affect us. It also could go from the duck to us, but usually there's a excuse me, there's usually an intermediary there which amplifies the infection, and then we amplify it amongst ourselves. So the H1N1 influenza began in ducks. They infected pigs. In some instances, the pigs then infected some humans because of our handling of them and so on. And pigs also develop a pneumonia, cough. And then we, in turn, spread it very effectively amongst ourselves.
Okay, there's a question. Yes.
There's another question that says, coming back to control, elimination, eradication, and extinction, is there any frontier between control and elimination? Both are aiming at reducing incidence and prevalence. Well, this is true. That is, when one controls an infection, the next stage, if one can do it, is to eliminate the infection from a particular region, a country of the world. That is not the same as eradication. Eradication means that there is no natural reservoir anywhere in the world. Now, some conditions we will not. It is unlikely that we will be able to control it, but we'll be able to control it. Let's say, such as polio, and polio has been eliminated from most countries of the world. We're able to control tetanus of the newborn, neonatal tetanus, through immunization of infants, and also immunization of their mothers, so during the birthing process they don't become infected. Now, we should, and in many countries we've eliminated neonatal tetanus. We can't eradicate tetanus truly because the tetanus bacilli is in the soil. And so if someone does not, if immunization does not continue, we remain vulnerable, okay? So unlike smallpox, which has been eradicated, we don't have to take the smallpox vaccine anymore. It's no longer, smallpox is no longer in the environment. So nobody born after 77 has been immunized against smallpox because that's when it was eradicated. We will have to continue, however, to be immunized against tetanus because the bacillus still exists in the soil, and we can't eliminate it. It's there. Both of them, as you note, are trying to reduce incidence and prevalence, and you can eliminate, you can control, you can go to elimination, but eradication is yet one additional step, and that's where we are with polio. We've controlled it in most countries of the world. We've eliminated from 98% of the countries, but it still exists in 3 or 4 different countries. And as long as it exists, the potential is there for it to enter a country that may be vulnerable. That is, let's say a country says, well, we haven't had measles in the last 10 years, let's stop the vaccine. And they stop it, but somebody enters their society, their country, with polio virus in their stool, that disease can go from control to elimination to epidemic, because protection has not continued uh, uh, because people thought, well, it's gone, but it hasn't been gone. It still exists. And that's the problem that the global community has right now. How long do they want to stop the polio vaccine, but they can't because it's still, the polio virus still exists.
Okay.
Another question is development of vaccines the most effective strategy to combat diarrheal diseases? Well, with diarrheal diseases, there are many causes. They will always be with us. We will be able to reduce the incidence, the number of new cases, with certain vaccines. The latest one is the rotavirus vaccine. The cholera vaccine has some effect, but it doesn't last that long, and so it's not considered an effective vaccine to continue to give year after year after year, because the protection is short-lived, 3 years, 4 years, and so on. There are vaccines against Shigella, but they're not particularly good. There are some E. coli, another pathogen, they may develop a vaccine, but it's not going to be unlikely to be particularly effective. Measles vaccine actually significantly reduces the incidence of diarrhea in certain places, because measles actually causes diarrhea. It's an infection that affects the epithelial layer, so both the lungs and the gut are affected by measles, and they can cause diarrhea and pneumonia. So there's some conditions that where there's a vaccine going against a particular pathogen. There are some vaccines that have a spillover effect, such as measles, but there are some conditions for which they will not, it is unlikely we will develop a vaccine. So what do we do? Well, we have now, and for many years have had a quite effective treatment to replace water and electrolytes, and this is called oral rehydration therapy. And that, after all, the pathology or the ill effects from diarrhea are because of the loss of fluid and electrolytes. So the individual becomes dehydrated. It's like being out on the desert for 5 days, but it all happens in 5 hours. So we still have to have treatments that will replace the water and electrolytes that people lost. And in some cases, not very commonly, frankly, antibiotics may eliminate the pathogen, reducing the duration of the diarrhea. But most diarrheal illnesses that particularly affect children they have a limited time span, 24, 48 hours, and the key there is to, if you can't prevent it, to at least make sure that the child is well hydrated and therefore will not suffer the severe effects, including death, from this condition. Diarrhea is a constellation of many different causes. Next question is, I'm from Assam, which is a state in the northeast of India, and presently we are having a rise from MDR TB, that's multiple drug-resistant tuberculosis. As a public health person, what can we do to prevent this problem? Well, MDR TB, in fact, all drug-resistant organisms are particularly problematic and becoming more so. The reason being is that the treatment, if there is a treatment, is often much more expensive and much more difficult. And that's the case with MDR-TB, where the cost of treatment is maybe 100-fold times that of the treatment of regular TB, and it takes longer. It's a much more complicated thing. What's the best thing that we can do? The best thing you can do is to ensure that you have a very good DOTS program. DOTS is directly observed therapy, short course. Much of the resistance that develops is because illnesses are not treated completely. That is, somebody has treatment for, the treatment for TB is 6 months. So somebody may be treated for 2 weeks or 3 weeks and says, well, I'm feeling so much better, I'm going to stop this. The problem is that the treatment hasn't killed everything. And those organisms that survive oftentimes will develop patterns of resistance. So by people starting and stopping and starting and stopping, we increase the risk of the development of drug-resistant organisms, such as MDR-TB. MDR-TB is not something that we're going to be able to treat our way out of because the cost in India particularly, and in most parts of the world, is quite high. And at least for the moment, the last 5 years, the price has actually gone up. It hasn't come down. And so, and also the dilemma we have is identifying those cases that are drug resistant. Unless you have a special machine, special diagnostic machine, which is not present in most of the country, you cannot diagnose it. You only diagnose it when the patient doesn't respond to the traditional therapy. So if they don't respond, then the strategy is you test it. If it's resistant to standard treatment, then you have to put them on a special treatment for MDR-TB. But this diagnostic material doesn't exist in most parts of India. A few centers it does. But even with that, it still raises the problem that some people who have tests for MDR-TB actually respond to the traditional treatment. So it's very problematic. The real issue here is preventing, and preventing is making sure that you have a strong and effective DOTS program. And then secondly, that you can diagnose cases should they not respond. And thirdly, that you can then treat them. But right now, as I noted, the cost is very, very high. Will we be able to get the cost down to much lower levels? It'll never be as cheap as DOTS. It'll always be more expensive and more difficult to treat these cases. The next question is, when we get to elimination, like with polio in most of the countries, why is it so difficult to move to eradication, given the disastrous consequences for people that can suffer from the disease? Well, as I noted, eradication is a global definition. So, and the difficulty in eliminating the virus from some parts of the world is where there is civil unrest, where there is war, where there is where people are moving around, where there is distrust of government. In these situations, the people themselves may not wish to present themselves for the government to immunize them. They may not trust the government. There may be other elements in the society that are totally opposed to the government, and since vaccines is generally a government activity, can be NGO as well, they reject it. So in rejecting the government, they do it through the rejection of the immunization. They are far less concerned with the global impact of this. It's not our problem. You want to get rid of it globally, you go and you do your thing. But our problem is right here in Afghanistan or Pakistan or northern Nigeria, where there is a lot of civil unrest, where there are terrorism is going on, where there are many wars going on. In these environments, it becomes very difficult to make sure that the entire population is covered with a vaccine. In some parts of the world, they've even assassinated people who are giving vaccine. Hard to believe, but it's true. And therefore, who wants to go there and give out the vaccine if you risk your life as a vaccinator to do it? So for at least now, those people who are working in the polio eradication campaign remain optimistic that by, I think, 2018, they will have eradicated the disease. I probably don't share that level of optimism. And the other problem we have with polio is that for every million doses that are given, there are a few, very few, that will revert to causing disease. So as long as we continue to give the oral vaccine, we always run a small but still perceptible risk of reintroducing polio to the population unless they are covered with IPV or injectable vaccine, the Salk vaccine, as opposed to the oral, which is called the Sabin vaccine. Now, there are many, many different, there are a number of strategies that have looked at this issue, have tried to deal with it, and have been successful to varying degrees. But as long as civil and significant civil unrest is occurring in areas where there are lots of children, and there are lots of children in all these areas, there are going to be problems. Polio is also problematic because it's not like one infection equals a case. There may be 100 infections to get one case. So, but those 100 infections can continue to spread the disease, just like the case can. So there are a lot of inapparent, we call this inapparent infections. Infections that we cannot define, but they're still out there. The way we determine infection is through looking for acute flaccid paralysis. There are measures that we can use. But for every case we find, there are many, many, many others who are infected. How do we corral all of those in has been one of the dilemmas that have been faced by the global polio eradication campaign. The next question before us is the following. Can a disease, once eradicated, reemerge due to drug resistance or any other cause? So, once a disease has been eradicated, can it be reintroduced? Yes, it can be reintroduced by somebody taking, remember, eradication is where there is no natural infection in the world. But what if it's in somebody's laboratory and that person is an evil person and decides they want to infect others, or they want to they threaten to infect others unless money is given to them? What happens? Right now, the smallpox virus, smallpox has been eradicated, exists in 2 laboratories, one in the US and one in Russia, supposedly under very, very stringent conditions that it is not accessible. What if somebody has access and spreads it? It's possible. But there's another issue that is coming up that we haven't taken full cognizance of, and that is we can now synthesize some of these viruses in the laboratory. As long as we can do that, and if those synthesized viruses can cause disease, can we ever truly eradicate diseases? And there's some people who feel that we should get rid of that term, eradication, because in fact we are vulnerable to science in this. The only other disease that is close at this point is polio. We have eradicated a disease in animals called rinderpest. Rinderpest is a condition that caused a lot of illness in animals, and the virus is very similar to the human measles virus. The feeling is that, in fact, we got measles from rinderpest, that measles was originally a zoonosis. Okay, and the potential exists, but in today's world, today's complicated world where people can move about very, very effectively, very inexpensively, can we truly ever eradicate a disease? Or will we always be this close but not quite? There is a Greek legend called the myth, or called that evolved around a human by the name of Sisyphus. And Sisyphus angered the gods, and they decided to punish him. And the punishment was to roll a giant rock up to the top of a hill, and just before it got almost there, it rolled back down again, and he'd start up again. Sometimes some of our efforts in eradication almost take on that characteristic. The next question that has appeared is, neglected diseases have been neglected for some time. How can we ensure that drugs are actively developed for such diseases? And how can we address economic interests of developers and the health interests of patients? Well, this is a dilemma, and let's go to the Ebola situation. Okay, here was an emergent disease, not a neglected disease. Neglected diseases tend to be those conditions that are present, but we haven't spent much money doing research on them. But well, let's say that Ebola is a neglected disease. The dilemma here is that if a company is going to make drugs, and most of the drugs are made by pharmaceutical companies, they want to feel that they're going to make a profit. Okay, they're not in the business of being altruistic. If they are, they're going to be out of business very soon. And so they say, well, can we make any money on this? I say, well, not likely, because Ebola is a disease primarily of very poor countries and very poor people in very poor countries. We also have to have enough of that disease to test medicines. We have to have first the ability to make a medicine against that disease. Then we have to test it out. And if we have a vaccine, which takes years to develop, we also have to test it against, see if it'll prevent disease. These are very complicated activities, costing a lot of money. What if only 500 people a year get it, or 5,000 people a year? Where is the incentive to invest a lot of money, a lot of scientific expertise into controlling that? It becomes very difficult. And that's why some of the neglected diseases remain neglected. That is, either they don't cause enough severe disease, or the people who are affected by that disease represent economically the lower rungs of society. So they may not be able to afford anything, or there may not be enough of that condition. And therefore, people doing research, there's less and less money for that research. There's less and less money to develop drugs and vaccines and so on. And then, frankly, then there's also the limitations of science. How many billions and billions of dollars have been poured into the development or the attempts to develop an HIV vaccine? We don't have one. We don't have one. And there is none really right on the horizon. Even if one came out today, it would take another 5 or 10 years to test it. So sometimes there are limits to how we can try to defeat Mother Nature, who can be rather clever.
Dr. Cash, I have a question of my own.
Fine.
This is related to the recent outbreak of H1N1 in India. What role do you think effective and regular communication by public health professionals can play in a situation where sort of media coverage is not is sort of out of proportion to the threat of the illness? So we've seen that the number of deaths attributable to H1N1 in this outbreak are pretty similar to the standard seasonal flu.
Well, I think that the public health community there are a number of things that it can do to try to not only prepare people for an epidemic, but to prevent the inappropriate response, either too much or too little. In this case, maybe too much. So people are running out and buying all kinds of drugs and treating themselves with antibiotics, and oftentimes inappropriately. I think in the first instance, it's getting the right information out to people through various media. And the medias are now greatly increased. There's Twitter, and there's Facebook, and there's TV, and there's radio, and there's testimonials of people in movies, all sorts of different ways to do it. But you need to simplify the message. That is, if you get what looks like a flu, and it may be H1N1, it may not be. The important thing is to not come to work where you're going to infect all of your colleagues. It's to take lots of fluids, and then if you have certain signs and symptoms, then you could go to a health facility. But far too many people go to health facilities. In fact, the worst place to go in the flu season is to the hospital, especially if you don't have the flu. If you want to catch it, then go to the hospital, and believe me, there'll be somebody there who will be only too happy to spread their virus onto you. So most of this can be dealt with at home. And since this disease is turning out to be relatively mild, there will always be people who will succumb to it for a variety of reasons, usually because they have other complications. They're elderly and have other illnesses such as diabetes and so on. Most of the deaths that have occurred with H1N1 have been in people with other complications. So these are messages that have to go out. By the same time, you've got to make sure that the people who are telling you that the sky is falling, if you remember that little children's story about Chicken Little who ran around and said, the sky is falling, the sky is falling. They're out there selling newspapers. And so, but that said, we need to have more courses and workshops for journalists. It's surprising how few journalists in the newspapers and in the media really understand these issues. I don't think that most, certainly responsible journalists, want to cause panics, you know, but they are also vulnerable to misinformation. So we have to establish reliable sources of information. We have to make sure those messages get out, and we have to make sure that that all of the media behaves in a responsible fashion. That said, there are going to be times when people will decide that they know better, and they're going to run away. You know, many years ago there was a supposed outbreak of plague in Surat, and within a day or two everybody ran away. Well, let's say there really was a big outbreak, and I'm not convinced that there was, but let's say there was. What is their running away going to do? It's going to spread it to other places. You know, they take it with you. You know, when you travel, whatever's inside you is going with you. Usually on a free trip. So, generally speaking, I think people want to be sensible, but they have to be convinced, and therefore, the public health community, which oftentimes sits on its hands, doesn't really get out there and do the kind of information, and it's not just writing one article, it's appearing on TV and radio and in schools and so on to get the message out. Messages don't go out one time and then that's it, we've done our responsibility. There are many different forums, and we have to be out there telling people what they should be concerned about and what they shouldn't be concerned about. I've seen people here coming into work who clearly shouldn't be at work. They're sneezing, they're coughing into their hands, they're touching the table. By the way, a lot of the flu we get is not from somebody coughing in our face, but touching a surface where there are the flu viruses. Why are they at work? Why doesn't their supervisor say, please go home and come back when you're over your illness, because you're infecting the rest of us? And how many did you infect on your metro ride here, right? So that sort of thing has got to be more effectively delivered. That said, again, clearly we don't do a particularly good job because some of these illnesses spread really quickly.
We are running out of time.
Okay.
So
how many more?
We have a few questions, but some of them we can answer on the forums later. There's a question here about your work on ORS.
They say I'm being humble by not speaking about myself, but this is not a course about me. I would want to know the highlight to everyone in this course that he and his colleagues were one of the first to do clinical trials for oral rehydration therapy. This is from Deepak. Thank you, Deepak, for that wonderful endorsement. Deepak and I are not in any way related, so I just want that was purely a spontaneous contribution on his part. Thank you very much, Deepak. I appreciate that.
I have a related query. I mean, if given in the light of the highlight by Deepak, what is the role of sort of simple, effective, cheap interventions in dealing with infectious disease and things like this? So ORS was a classic example of how a very straightforward but simple intervention brought about great change in diarrhea disease.
So what the question is, are there inexpensive interventions that can in fact have a major impact? Yes, there are. But we have to make use of them. In the infectious diseases, as I mentioned, hand washing after one goes to the bathroom would go a long way to eliminating the spread of certain diseases, especially where food is being prepared and so on. So that's one intervention. You mentioned ORS is one. There are, when one coughs or sneezes, there's a way of doing it so that you don't spread your illness. You stay home. These are all low cost. They don't cost anything, in fact. And in other aspects of our health, not infectious diseases, but whether it's exercising on a daily basis, whether it's not smoking, whether it's watching our diet, these are all low cost, no cost interventions. And yet we don't always follow our own, we used to say, physician heal thyself. We don't always follow our own observations, our own recommendations. But there's a lot that can be done. That said, if there's a severe infection and you need penicillin, well, then you have penicillin. But there are ways to prevent other kinds of illnesses, sexually transmitted infections. Many of these can be prevented through the use of condoms, so that where one does not have a steady partner, so that the prevention of fluids between individuals having sexual intercourse. Condoms don't cost very much. Hand washing doesn't cost very much. And so on. There are a number, if we would actually list all of these, the cost is relatively low, and it is not the highly expensive, very specific interventions that have improved the overall health of populations. It's been these lower cost ones that have done more than the fanciest surgery in the world. Well, thank all of you very much, whoever has participated in this. I have no idea. I'm simply looking at myself here and watching myself talk, but I can see that a lot of people ask questions, and those that we've not been able to get to, we'll try to do it either at another session or through the folks here will figure out how to get these answers to you. But thank all of you. Let me thank all of you for participating in this, and I hope you found it to be a worthwhile and educational experience. Thank you.